Virtual reality as an automated stress reduction therapy tool. Case study on war refugees by Vauxhall Research Lab.
The conflict in Ukraine broke out on February 24, 2022, leading to a significant influx of refugees into neighboring countries. Primarily women and children, since men of draft age were prohibited from leaving Ukraine. As a result, over 3 million refugees arrived in Poland in a brief span. Many women and children faced an entirely unfamiliar environment, often lacking basic personal items, money, or a secure place to stay. Separated from their loved ones who remained in war-torn cities, these individuals experienced high levels of stress. Leveraging prior experience with VR for stress reduction, we created a Ukrainian language VR therapy app. The proposed version of the VR application is in the form of a cozy apartment in the mountains. During the session, participants relax on a comfortable chair in any convenient position. The narrator assists throughout the session, acting as a therapist. A short adaptation scene precedes the therapy scene. First, the user is asked to look around the apartment and get comfortable in the chair. Then, the user moves seamlessly into the therapy sessions, which involve various relaxation techniques, such as breathing methods, visualization, and bilateral stimulation. For this specific group, we eliminated the cumbersome EEG wet cup by replacing it with a discrete, HDM-integrated, dry EEG Luxit link at the expense of reducing the number of channels. The EEG system remains almost unnoticeable. Users did not complain about the inconvenience. We also used a GSR sensor with a convenient mounting on the user's fingers. Before and after the session, users fill out general health status questionnaires and GMS so that we know their subjective feelings about their mental state, the intensity of stress, and the emotions accompanying the moment. In March 2022, we launched an information campaign together with Łódź City Council. To increase the level of trust, we hired a Ukrainian refugee who was in charge of recruiting subjects for VR sessions. Finally, we recruited 55 participants, 52 female and 3 male, aged in the range of 18 to 70. The study was conducted in a period when the university was closed and there were no students, in a quiet, air-conditioned room. We provided a shopping voucher for the equivalent of $20 as remuneration for participating in one session. We underestimated the deep distrust and skepticism of refugees who found themselves in a foreign country with limited resources and often incomplete family units. Despite the warm initial welcome by Polish society, Ukrainian refugee communities were initially closed, suspicious, and paralyzed by fear of meeting their basic existential needs. In the early stages of their stay, refugees frequently changed their place of residence in order to find one that would guarantee the satisfaction of their basic needs. Other priorities and concerns overshadowed therapeutic considerations. Various channels were used to reach our target group, including city authorities, official government refugee registration offices, non-governmental organizations providing refugee assistance, local media, and social media platforms. Surprisingly, we were flooded with numerous questions suggesting that even the subject of therapeutic assistance at a national university had to be sufficiently credible. The idea of formally hiring one of them to help with the project emerged and became a turning point. Someone with a background in war refugee communities found it much easier to connect with the target groups, largely due to direct access through social media and the common language, eliminating language and cultural barriers. Some of the refugees, for reasons beyond our control, did not complete the full series of tests. Only 30 subjects participated in all offered sessions. 6 relocated and were not able to continue participation due to a very inconvenient commute. 8 people returned to their country of origin. 11 people, without giving a reason, did not report back to participate in further sessions. only 2 of the recruited subjects had any previous exposure to a VR experience. Participants of the first sessions in the conducted interview made it clear that they were astonished by the level of immersion and very keen on exploring the presented VR environment. It is likely for this reason the expected measurable objective therapeutic effect was obtained only during the second and subsequent sessions, 89% of cases. The recording of biomedical signals did not cause any critical problems. Thanks to the adopted procedure of placing the GSR sensors on the index and ring finger of the left hand, we did not have any case of shortened contacts or discontinuity of measured quantity. Similarly, we did not encounter any issues with recording eye tracking signals and HMD localization. In contrast, monitoring EEG signals proved to be more troublesome. Since the vast majority of participants were women, applied face makeup was a source of some problem. Dry, lucid electrodes sometimes lost good connection with the skin. In one case, getting a stable EEG signal was impossible due to the very low forehead of the participant. It is worth mentioning that the HMD mounting procedure included the need to expose the forehead by moving away the fringe, as contact of hair with EEG electrodes virtually always leads to temporary or permanent loss of signal. We were initially too optimistic about scheduling therapy sessions. In spite of our best efforts, it was challenging to keep the sessions on track. Being in an unfamiliar city, suffering from communication problems, and having no experience in using local public transport caused trouble when reaching our university and thus significant delays in our schedule. The rise of national threat level connected with the situation in Ukraine caused increased security measures to be introduced in public institutions. The participants had to go through security and identify themselves, which often caused additional setbacks. We have noticed a lack of empathy from the facility's security personnel. Another unforeseen logistic problem was that women often attended the sessions accompanied by their young children. Providing the children with care and entertainment during their guardian's session was an additional challenge. Fortunately, we swiftly organized a set of building blocks and provided colorful crayons and markers. The results were promising and showed that VR-based BLS is efficient in mood improvement and stress reduction. These effects are also related to a decrease in the subjective perception of stress levels. Data analysis shows that the repetition of VR training does positively affect its efficacy in symptom reduction, which is relatively stable from one session to another. Taking into account the special sample we worked with, our results are more than promising. Thanks to the press conference and various media publications in newspapers, the internet, radio and television, we had no problems recruiting volunteers for our study. Additionally, we were contacted by many NGOs interested in implementing the application at their spot. Since our solution was designed for research, it was rather unsuitable for such applications. The hardware is expensive and additional trained personnel is required. Thus, we prepared a simplified version dedicated to the Oculus Quest 2 HMD, supplemented with a self-service IU. This version has been designed for individual users or patients receiving therapy sessions at a therapy clinic, at home, or refugee assistance center. We have also received information about the need to implement the system in elementary and secondary schools due to the fact that many children have problems with adaptation. Unfortunately, after consultations with a child psychologist, it turned out that the created scenario will not fulfill its purpose.